Hello.
Yes, sir. Your voice is clear and the screens are clear. Screen is clear as well, sir. We can see your
Okay.
screen.
Thanks. Okay. So today the topic is basically the failed back surgery syndrome. As you know, these patients, in spite of very good surgery and at the right level by the expert surgeons, but still there are people who still have the pain after the surgery. And this is that's why they call it failed back surgery syndrome sort of thing. Because syndrome we call it because it has multiple pathologies, which we'll discuss later. So, so this is my disclosure, and these are my mentors, Professor Gabor Rag, James Evener, and all those guys. I had the honor to learn these procedures from these legendary teachers directly, alhamdulillah. So this picture shows you that there is a runoff on the right side, but left side there is no runoff. So if we give a simple epidural to this patient, we won't be getting the good results because the adhesions and all this fibrosis and the pathology is on the left side, which is not letting the medicine go there. Maybe we'll have a transient small relief because of local anesthetics. But when we put the catheter on the left side in the L5 foramen area and we start adhesiolysis, we'll see that the runoff starts and the left L5 and F1, they start opening gradually with the epiduroplasty. And here you can see the nicely made Christmas tree is there of the same patient. Similarly, in the cervical area, in this patient at T1, T2, let's see, 71 level is my entry point. Here, when I did the epidurogram, I found that most of the dye is coming down because but not going up towards the area which was my target. So after passing my catheter to the desired area on the left L5, C5, C6 area, so I was able to do adhesiolysis, and here you can see very nicely opened left-sided foramen, which were the target of my procedure. So the epiduroplasty is basically gives a targeted approach towards especially towards the fibrosed areas, and which is commonly the cause of failed back surgery syndrome pain, low back pain as well as radiculopathy. So these pictures I'm just showing only just to show that how important it is to be targeted in patients with have adhesions in the epidural space, and our target is basically the anterolateral epidural space in whole the spine. So in failed back surgery syndrome, we can do either redo surgery or simple epidural. Sometimes they do work, and but not always. And epiduroplasty, simple epiduroplasty or epiduroplasty with frequency ablation and spinal cord stimulation. And I have also done the percutaneous endoscopic lumbar discectomies in the patients who had reherniation of the disc in the already operated areas. This is a very latest. This is a very latest paper by the Manchikanti and his friends, and it was published in January 2023. And they have told that this systemic review on the epiduroplasty with meta-analysis utilizing the appropriate methodology with the qualitative and quantitative evidence synthesis with conventional dual and single arm analysis show level 2 and level 1 or moderate to strong evidence of the effectiveness based on the 5 high quality and 2 moderate quality RCTs with 1 year follow-up showing improvement in pain and function as well as a decrease in opioid consumption. So regarding the introduction, you know the chances are relatively high that each of us will experience low back pain at some point in our lives, and the usual course is rapid improvement with 5 to 10% to develop persistent symptoms. Treatment typically begins with conservative measurements such as medication and physical therapy, and may even include the minimally and highly invasive pain management intervention. Surgery is sometimes required in patients who have progressive neurological deficit, and those who do not respond to the conservative treatment sometimes choose surgery. A quandary sometimes arises following a primary surgery as to whether repeat surgery should be attempted or another alternative technique should be tried. This is the exact problem that the epidural adhesiolysis procedure was designed to address. Epidural adhesiolysis was given an evidence rating of strong correlation to a 1B and 1C evidence level for the post-lumbar surgery syndrome in the most recent American Society of Interventional Pain Physicians evidence-based guidelines. Understanding the etiology of failed back surgery syndrome is the crux of the story. And if we understand this pathology, we can nicely treat these patients who have failed back surgery syndrome. Ateeq et al. Addressed this issue when they studied 193 patients who had undergone lumbar spine operations, given local anesthetic into the epidural space. It was postulated that the sciatica could only be produced by stimulation of a swollen, stretched, restricted, that is, a scarred or compressed nerve root. Back pain could be produced by stimulation of the several tissues, but the most common tissue of origin was the outer layer of annulus fibrosis and the posterior longitudinal ligament. There are many possible etiologies of the epidural fibrosis, including surgical trauma, annular arterial infection, hematoma, or intrathecal contrast material. LaRocca and McNabe demonstrated the invasion of fibrous connective tissue into the post-op hematoma as a cause of epidural fibrosis. Cooper et al. Reported very radicular fibrosis and vascular abnormalities occurring with herniated intervertebral disc. McCown et al. Investigated the irritative effect of nucleus pulposus on the Diva sac adjacent nerve roots, and the nerve roots live independent of the influence of direct compression on these structures. Park and Watanabe showed the significant evidence of adhesions in cadavers with lumbar disc herniation. It is widely accepted that the post-op scar renders the nerves susceptible to injury by a compressive phenomena. The scar tissue is generally found in three components of the epidural space. The dorsal epidural scar tissue by the resorption of surgical hematoma, ventral epidural space by the dorsal defects of the disc, and the lateral epidural space susceptible to the lateral disc defects, such as hypertrophy and neuroforaminal stenosis. Kashif et al. Summarized that the presence of scar tissue compounded the pain associated with the nerve roots by fixing it in one position and thus increasing the susceptibility of the nerve root to the tension or compression. They also concluded that no other tissue in the spine are capable of producing leg pain. Ross et al. Demonstrated that subjects with extensive peridural scarring were 3.2 times more likely to experience recurrent radicular pain. This evidence also parallels a new study by Gilbert et al., in which lumbosacral nerve roots were identified as undergoing less strain than previously published during straight leg raise, and in which the hip motion greater than 60 degrees was demonstrated to cause displacement of the nerve root in the lateral recess. So fluid foraminotomy means breaking of the adhesions with the help of fluids. Just to break the adhesion and disentrapment of the nerve. Relative of functional foraminal root entrapment syndrome secondary to the epidural fibrosis with corresponding nerve root entrapment is frequently evident after an epidurogram and signified by lack of epidural contrast flow into the epidural fingers projection at those levels, as I have already shown you in the first picture. The lysis procedure effectively serves as a fluid foraminotomy, reducing the foraminal stenosis caused by the epidural fibrosis. In addition to increasing the foraminal cross-sectional area, adhesiolysis serves to decompress the distended epidural venous structure that may exert compression at nearby spinal level and inevitably cause needle stick related epidural hematoma. This is a epiduroscopic picture showing fibrosis and engorged venous plexuses, and which are very commonly injured by the catheters during the epiduroplasty. And they also cause compression on the adjacent nerve root to produce radiculopathy. Another picture showing the cadaver engorged blood vessels in the epidural cavity in a cadaver. See the veins on the right side next to the nerve root target site for fluid foraminotomy and opening venous runoff and decompression. So this vein engorgement can cause pressure on the adjacent nerve root. Regarding the diagnosis and radiological diagnosis of epidural fibrosis, as with any patient, a thorough musculoskeletal and neurological examination should be performed. In addition to standard dural tension provocative test, we recommend to provide provocative test called dural tug. A positive dural tug maneuver has been observed to resolve after the percutaneous neuroplasty. The dural tug, whenever there is a fibrosis between the epidural posterior longitudinal ligament and the dura, the stretching of the dura by flexion of the neck will cause pain in the posterior longitudinal ligament, which is full of C fibers. So in this patient, Professor Gabor Rag has kindly given me these pictures for presentation, in which show that the flexion of the neck is painful before the procedure, and but pain is no more there after the adhesiolysis. Similar patient with the dural tug is now negative for the dural tug because adhesions are broken by the adhesiolysis. This young girl had this adhesions at T9 and T10 level, and after the adhesiolysis, she was able to flex her body very nicely without pain. MRI and CT are diagnostic tools. The sensitivity and the specificity are 50 and 70% respectively. CT myelogram may also be helpful, although none of the aforementioned modalities can identify epidural fibrosis with 100% reliability. In contrast, epidurography is a technique used with considerable success, and it is believed that the epidural fibrosis is best diagnosed by performing the epidurogram. It can detect filling defects in good correlation with the patient's symptoms in real time. A combination of several of these techniques would be undoubtedly increase the ability to identify epidural fibrosis. Indication, as we already talked, is failed-back-surgery syndrome or post-laminectomy syndrome of the neck and back after surgery, disc disruption, metacarcinoma, mets of the carcinoma in the spine, multiple degenerate arthritis, facet span. I mean, these are all things which we can do with the uh, simple epidurals are also the indication for this. Contraindication like sepsis, chronic infection, coagulopathy, local infection, patient refusal, or some pathology in the dura in the spinal cord. A relative contraindication is arachnoiditis. Patient preparation, the same as consent and discuss with the patient about the benefits and risks of the procedure. And after the consent, we can go ahead with the other things like anticoagulation is very important. And there is standards of that stop NSAIDs and spin and other blood thinning medications well before time, and ask for INR, PT, APTT, and BTCT, and also simple CBC. Pre-op lab, also urine analysis is very important in these patients, and sometimes they have infection in the, and some patients with the failed back surgery syndrome, sometimes they have some loss of control on the bladder, and so sometimes when I find a patient with the having some compression on the nerve roots, so I observe for the filling bladder status also on the MRI, and if I find it's full, then I advise that he should have a simple ultrasound pre and post voiding, because sometimes after performing these procedures on the spine, because of local anesthetics, if these patients already had some compromised neurogenic bladder or some obstruction in the bladder because of hypertrophy of the prostatic tissues, they just put blame on us that because of this I had this urine retention. So always go for it if you suspect that this patient has some urinary retention issues also. Technique is like this procedure is performed on cervical, thoracic, lumbar, and caudal region. And we perform this procedure under strict sterile conditions in the operating room. Prophylactic antibiotic, I always give ceftriaxone 1 gram before the procedure to every patient. And commonly the caudal approach we use. And there are so many things we can discuss, but mostly we learn these things under the supervision of some mentors or some people who are already doing it. That is the best way to learn the techniques. And this technique, and you show we go from the this sacral hiatus, and but the best thing is just go and learn under the supervision of your mentors who are already doing this procedure. And I myself am using the RX needle and the Epimed stuff I use myself, and was a cat and all these which are made by the Epimed USA. And remember that the RX needle is different from the TUI needle because its end is not sharp. So it doesn't have a cutting end like the TUI needle. So when we pull back the catheter, it commonly comes back very nicely without any shearing off. And so always use the right stuff for this procedure. And never advance the RX today beyond sacral 3 foramen, because we may puncture the low line dura sometimes. Epidurogram is performed using 10 ml of non-ionic water-soluble contrast, I always use isohexol or Omnipac or Ultravist myself because they never cause, most of the time they are very safe and they are water-soluble and they don't cause any reactions. They're very safe. And accidental subarachnoid injection can lead to serious untoward events such as seizures or possibly the death. But don't worry, we do all these procedure under fluoroscopic guidance and we see everything what we are doing. The most important thing which I am going to stress here is in a patient who already had a surgery on the spine, never advance this catheter RX today, this is Vorzacat, never advance in posterior epidural space. Always advance in lateral or anterolateral, posterolateral areas because these areas don't have much of the scar. And if you do perform epiduroscopy, you will find in these patients that the dura is badly stuck with the body tissues, with the muscles and the fats and all that, and it is very difficult to advance the catheter in the posteriorly in the center. So whenever you are performing this procedure, always advance this catheter in the lateral gutter of the epidural space. Don't force it. Otherwise, you will go subdural, and subdural means intrathecal. Sometimes you find, as you have seen, the engorged venous plexus. Because of this, you may stuck into some engorged vein, and you will see the venous run also. And sometimes you find both venous run plus also epidural run out. In these conditions, it is because mostly the pressure inside the epidural rises because of the fluid dye, and this is forcibly absorbed into the engorged veins. So they find some runoff. So if you don't give any local anesthetic and you simply keep giving some normal saline and breaking the adhesions, gradually you will see this venous runoff will stop, and only the epidural and transfemoral runoff will be there. You see on this right side, there's a normal epidurogram showing the dye along the nerve roots, and on the other side, there are adhesions and only scanty epidurogram is there. So this is a technique, actually, you have to learn it. And what I have found myself commonly, the female sacral area is very easy to approach for this procedure as compared to the males because they have very acute angle. But when you start learning it and you coming across different type of curvatures of the sacrum, you will be gradually there how to handle these things. So there is not a standard technique that you make this angle and this angle. This is all you learn with passage of time under the guidance of your teachers. Myself also make an angle at the tip because it helps me to navigate the catheter to the desired level. So this picture is showing this catheter in the right L5, L4 format. So these techniques I already told you, you have to learn these techniques under the supervision and perform yourself. And those who already doing the epidural injection, they must switch over to this technique because this is very rewarding, and you can treat difficult cases with the help of this, because in simple epidurals, we just give the medicine and we are not have no control on the fluid runoff, and we mostly don't get a good result for a longer time in the desired fibrosed area. So here you see the contrast omnipac is given, and mostly it's coming down, and that's the adhesions on the right side you can see. So these pictures you come across very commonly. The vascular runoff I already told you. And one important thing is that Professor Gaborrag et al. Have never observed intraarterial placement of in 25 years, more than 25 years of placing soft spring tipped catheters. So I myself have done thousands of cases, but Alhamdulillah never had arterial runoff. Venous can happen, and we can avoid it by looking at the venograms and all that. We also use the hyaluronidase. Hyaluronidase enzyme is actually helps in penetration of the medicines and penetration of the fluids into the fibrosed areas, and it definitely helps in opening the card areas. And now the people have thinking that even simple normal saline can help to open the fibrosed area. But in addition to the simple normal saline, the steroids and hyaluronidase also play an important role to enhance the effect of your treatment. Always use local anesthetic in a sensory dose. Never use a motor block dose for these patients. And there is no concept of using a motor block concentration of local anesthetics in pain medicine. Another picture showing the epidurograms and all that. This is a picture showing caudal approach. But you have to learn all these things. I also myself use hypertonic saline, because Professor Gaborrag is using of hypertonic saline in cervical, dorsal, and lumbar area very commonly. But the important point about using the 10% hypertonic saline is that always wait at least for half an hour after giving the local anesthetic and steroid solution to the patient. And if the patient have a good motor response, motor power, only then start giving the infusion. And 10% saline in 10 ml give by very slow pump is the best way is to give it by the syringe pump in half an hour time, because hypertonic saline causes irritation in the epidural space. It helps in many ways. Number one, it causes the scarring of the C fibers, which are susceptible to this hypertonic solution, and they decrease the pain sensations from that area. It also causes the fluid, more fluid comes in the epidural space and make it softer as compared to the other tissues because of hypertonicity. It attracts the water from the adjacent areas. Also good to decrease the inflammation of the nerves and the dural tissues by taking out the water from those inflamed areas. So these are the things about the caudal approach. And yes, what strategy we use? I myself use the strategy that either you give a single shot with the epiduroplasty and send the patient home. But the best result, which I myself found, is that you admit the patient for a couple of nights. You put the catheter inside, give hypertonic saline, steroid, and normal saline to the patient, and fix the catheter on the body. And the very next day, take the patient to the theater, give some dye that is to confirm the position of the catheter tip is not intrathecal or intravascular. So then just give normal saline to this patient with some local anesthetic and wait. And on third day, day 3, you repeat this procedure, and but don't repeat, give steroid later on. Just simply give normal saline and with local anesthetics, some local anesthetics. And after half an hour, just give 10 ml of 10% hypertonic saline. And after flushing the catheter, just put aseptic dressing and discharge the patient. This is what I do myself. Sometimes if the patient has an tear in the mid-spine, like L1, T12, T11 area, these patients commonly, they develop scar tissue between the posterior longitudinal ligament, the disc, ruptured disc, as well as the dura. So whenever the patient flexes his neck, he feels pain on the whole spine. So these patients are the best treated by transfemoral approach with the catheter, and just locally just take the adhesions, they put the catheter there, and this is a technique to be learned very, very effective. And I have found it very effective myself by performing this procedure in those patients who are dural tug positive, and on MRI found that T11, 12 or T12, L1 or L2 they had a posterior annular tear, and which is healed, but this causes a scarring, and scarring leads to the dural tug and pain, local pain in the back, and especially in the neck when the patient flexes the neck. So the transfemoral approach is very effective in these patients. So this is a patient which had this transfemoral. So sometimes the patients who have pathology in L5S1 area, we also go by the first sacral posterior femoral approach, and directly we go to that area, because there are studies in which they have found that the angle between the L5 and S1 traversing the root, there is a space, potential space is there, and this potential space sometimes causing scarring and fibrosis of both the exiting and the traversing S1 nerve root. So this approach, this area is very difficult sometimes to approach directly through the caudal area or transfemorally. So the posterior S1 approach is very effectively causes breaking of the adhesion in this area, and this is also very rewarding for such patients to have direct approach over there and do the adhesiolysis. So the complication, as I told you, never go for the midline placement of the catheter which enters the subdural space. There is also some epidural dye spread, and but the patient starts complication of bilateral leg pain. So this as I told you, never go through the posterior midline. In the midline, always advance your catheter in the lateral gutter of the epidural phase. Complications, hematoma, and I give a very much importance to one important thing, and that is loculation. Loculation means if you find that you are giving the dye to the patient, but it is just becoming bigger and bigger at one place, there is no runoff. So it is very important to stop immediately, because this will cause compression on the dura as well as on the nerve root. And sometimes if it is happening in the cervical area, sometimes it causes damage to the spinal cord that's in the cervical area. So the loculation is very important to be observed. So you should know there is some, just like egg-like appearance of the dye is there, but there's no runoff. So in these patients, the best way is just to take, pull back the dye you have given through the syringe and through the catheter. Don't displace or remove the catheter from there. Just gently suck out the this dye given over there, or you just some neural flossing movements of the neck or the body can do help in improving the runoff. So outcomes that I have already told you that the Mansi Kanti, they have recently published the paper and they have found it effective. So these are all the literature stuff. But the important thing is to learn it, learn the technique, learn the best way of the technique and how to manage it, the problem. So I always ask my colleagues to perform these procedures in a well-established operation theater, because the complications once in life is sufficient to destroy the career of a pain physician. And it's very important to observe all these standards and never perform these procedures in just outdoor clinic and just give it and go, because I myself have dealt with very complicated cases, and I found I never perform myself these procedures in just OPD clinics and something like that. I always perform these procedures in a well-equipped hospital and a well-equipped operation theater, just to keep myself ready to face any complications which I can come across during these procedures. Thank you very much. This is 54-minute talk, and I welcome any questions. Hello.
Thank you very much, Dr Jameel. Thank you very much. पढ़ाई आपने अच्छा प्रेजेंट किया, अपना पर्सनल एक्सपीरियंस along with the literature. Very interesting talk और very informative. मैंने कई बातें नहीं आपसे देखी सीखी, इस पर मैंने इंशाल्लाह प्रैक्टिकल लाइफ में यूज करेंगे.
I am performing myself this procedure very commonly in caudal area and transcranial or cervical. I do very commonly. And next time I will just ask my assistant to just announce in in the group when we have this procedure. So the couple of students who want to observe or come to join us, they can come to our Razi and observe the technique in person there. They are welcome, anybody.
ये जो आपने बताया कि ट्रांसफार्मर कैसे डालते हैं, तो कितने दिन लगते हैं कैथेटर आप और किन पेशेंट में यूज करते हैं?
Transforaminal, commonly you need a single session only. because it's very easy to break the adhesions because the catheter directly goes into the anterior epidural space towards the target, which we can see on the when you give a dye through the catheter in these adhesions, you will find a white spot right in the center where there is no dye.
Yes.
That means that this is a scarred area because there is no dye over there. So you target that area. Commonly, you can treat it in single session.
Yes. Yes. Thank you.
Yes, hypertonic vela. Somebody asked that. Professor Gaboraz do the 10-10-10 for the lumbar area. 10 cc of 10 mil of the isoaxole or dye, 10 mil of the local anesthetic with steroid, and 10 mil of hypertonic saline. So 10-10-10. So hypertonic saline 10 mil only. But commonly, I have seen the patient people, my colleagues doing pain in Europe and America. They sometimes transformally just give a cup of cc or 2 of hypertonic saline in every foramen. Also, sometimes they do this technique. For the Gaboraz, he always goes with the 10 mil of hypertonic saline in half an hour through the syringe pump. Very gradually, don't push it, and always keep observing the movement of the patient, because if you give it intrathecal, that there is a disaster. You understand all the complications. Any more questions, please? There is one question somebody is given comments, I don't know. Epiduroplasty may have more role in the failed back medical syndrome than the failed back surgery syndrome. Yes, as I initially told you, that the cause of pain in the failed back surgery syndrome is either the local tissues or the compression of the nerve roots. So with the adhesiolysis, we break the adhesion, and with the radiofrequency ablation, we treat the facet joint pain also. So it's very rewarding in surgical cases who have failed. But if there is no reherniation of the disc, then this is one of very rewarding procedures you can perform in these failed back surgery syndrome cases. Yes. Spinal cord stimulation. Dr. Komal has asked about the role of spinal cord stimulation. As initially I told that yes, spinal cord stimulators are one of the ultimate solutions in those 10 to 15% of cases who do not respond to any type of intervention. So this is spinal cord stimulation is one of the modalities we use in those patients who are resistant to glue. Now people are not using. Now people, especially the intercostal neuralgia, is very difficult to treat. These patients, intercostal neuralgia patients, we treat these patients with transforaminal injections in the intercostal block. We also give pulse radiofrequency of the DRGs of that, but still they don't respond. Especially the post-op intercostal neuralgic patients, these patients always respond to the stimulation, spinal cord stimulation, or to the DRG stimulation technique there. But they're very costly, we don't afford it. Yes, Dr. Sadaf Mushtaq asked about the role of sympathetic block and failed back. Yeah, sometimes this pain is a complicated thing. Sometimes sympathectomy helps these patients. But this is important thing is that you should look out of the box. How we can help these patients? So now people are doing so many things in every patient, and our goal is just to give a good relief to the patient, whatever is possible, physical therapy, even acupuncture, regenerative medicine, they are playing the role in this pain management. Hyaluronic dose is, one ampule has 1500 international units, and we mix it in 10 ml of normal saline for the lumbar area. But in cervical area, mostly I make 777 cc of everything, and 1500 units of hyaluronic acid. So the important thing is you must go out. You must start doing it. Okay, this is very important. And being an anesthesiologist is we as anesthesiologists we blind epidural. Even in labor and all that we put catheters and all that. Why can't we do it under fluoroscope guidance? So you should go ahead and go for the best techniques available for the relief of the patient, and they always appreciate you. So any more questions? So, hello, where is the host, chief host?
Yes, sir.
It's okay now. Should we finish now, or any question?
If there is no question, we can just end the presentation.
Okay, okay. We can. This is very interesting topic. This is next time we can give a good one lecture on the cervical epiduroplasty only. And this is very important, and we'll find something very interesting for the.
Thank you, Jamil. Thank you. We'll keep bothering you. Don't worry.
Okay,
We'll keep
sure.
bothering you.
My
Okay.
pleasure.
Thank you very much. Thank you. Thank you. Great.
Good luck, everybody. Have a nice weekend. Allah
Hafiz.
Hafiz. Allah Hafiz.